Okay.
And I'm going to try to go live. So Kevin, go ahead and stop your screen share.
All right. Gotcha. I'm off.
All right. This is supposed to take a few seconds. Tiger King.
Oh, and Kevin, if you or
my wife loves that crap.
If you
like all over this Tiger King stuff.
Have your Facebook volume on, you want to mute it because it will be a 20-second delay. It'll drive you nuts if you have the volume on.
And I think once whoever's giving the talk rests, just go ahead and mute your microphones also, I think.
Yeah.
All right, it's doing something.
Ashwin, you may want to try and get some foreground light. You're looking kind of silhouette-y there. Maybe turn off the overhead light.
And maybe get a Tiger King virtual background too.
Interesting.
Yeah, that looks good, Ashley.
It didn't ask me for the group.
Oh, it has to ask you for the group, or it's going to go random. So you should.
Right, I'm gonna try it again. Okay.
Yeah, because it will not go to where you want it to go.
Yeah, I'll try it again.
Hey, Ashwin, how are you?
You're muted.
I'm doing great. How are you doing?
Good. I haven't seen you since we were on stage together. Do you remember?
Yeah, of course. I try to forget that period of time.
Excellent points.
I drink a lot to try and forget that. How are you, Emily?
Good. How are you?
Congratulations.
Oh, thank you.
This the last one?
Well, that's what I said about the last one, and then I got
now
baby
it
fever.
seems
So.
we're going to the right spot.
All right, maybe I should mute myself.
Okay, me too.
Okay, it's preparing to go live now. All right, I can see my unpleasant face on the screen, so I think we are good. Can you guys check your phone or something to see if you can see us? And I only see the Tiger King, Emily.
Yeah, I can see us on Facebook. Yeah.
Can you hear anything?
Let me turn on my volume. Yep. Yep, I can hear you.
You can hear me? All right. Okay, so all right, welcome everyone to the SAGES Facebook seminar on alternatives to Nissen fundoplication. My name is Ruchir Puri. I work at University of Florida in Jacksonville. By and large, we have a fantastic panel of experts who are going to talk about modalities for treating GERD patients and alternatives to Nissen fundoplications. Hopefully in the next hour or so, we can outline their use to all of you guys. Before we get started, I want to thank Dr. Andy Wright, who has really spearheaded this Facebook initiative, and also Dr. Lena Khetan, who chairs the Foregut Foregut Task Force of SAGES. And also a shout out to Vanessa Chung and Ed Rosado from SAGES, who make these webinars possible. So I'll get the ball rolling with an operation that we all know really well, which is the Toupet fundoplication. Let me try to find this real quick. It should have been up, but it's not. Okay. All right. So again, an operation we all know very well. My only disclosure is that my partners actually make fun of me for doing too many Toupet fundoplications. So this is Dr. André Toupet. He was a French surgeon who devised this operation in the 1900s. So at that time, the predominant operation was the Nissen fundoplication. And even then, the side effects of Nissen, like dysphagia, inability to belch, gas bloat, were well known. So after hundreds upon hundreds of cadaveric dissections, Dr. Toupet came up with this operation. And there were two fundamental differences from a Nissen. One, obviously, it was a partial wrap. And Dr. Toupet did not believe in tight, if any, hiatal closure, because he believed that that was part of the problem as well. So he presented the operation to the French Academy in 1963 and gets severely criticized for the operation. So much so that when he retired in 1980, he had performed only about 20 hiatal hernia repairs. And so the Toupet fundoplication gets lost for a few years. And then in the early 90s, laparoscopy starts. Laparoscopic Nissen fundoplication becomes the predominant operation for acid reflux. And the Toupet gets rediscovered, mostly in Europe, again, for the same reasons, the mechanical side effects of the Nissen fundoplication. So this is one of the first studies to come out of Europe. This is from Hamburg. And the two primary surgeons, Zornig and Emmermann, even at that time had performed more than 300 laparoscopic Nissen fundoplications already. So they randomized 200 patients with GERD into a normal motility arm and a motility disorder arm. The motility disorder was defined as a distal amplitude less than 40 and more than 40% failed swallows. And both the arms were further subdivided into Nissen and Toupet, containing 50 patients each. So all these patients underwent preoperative endoscopy, 24-hour pH testing, and manometry, which was done preoperatively and repeated at 4 months. The Nissen fundoplication was created over a 36 French nasogastric tube, which is a pretty large nasogastric tube. And as you all know, most surgeons today, while doing a Nissen, will use a 54 to 60 French bougie. So much smaller than what we would use today. Also, these patients were admitted post-operatively, and the diet was advanced rapidly to solid food in about 5 days, at which point the patient would discharge. And again, that is slightly different from what we typically do. Most people will usually trial some liquids for a couple of weeks before transitioning to soft and then regular food. So looking at table 1, this is the profile of the patients. They're fairly well matched in terms of esophagitis, hiatal hernia, so on and so forth. In terms of preoperative dysphagia, not surprisingly, the patients with motility disorders reported more dysphagia. And at 4 months follow-up in both the normal motility as well as the motility disorder arm, and both in Nissen and Toupet, the patient satisfaction was very high. In terms of symptomatology after the operation, the patient with Toupet reported more subjective symptoms of regurgitation and heartburn, but on objective testing, they did not have significant esophagitis or abnormal pH testing. Actually, the Nissen patients did. Again, in terms of dysphagia, slightly in favor of Nissen, more dysphagia. And then looking at new onset dysphagia, which was not present preoperatively, the Nissen patients had more dysphagia, which was statistically significant. So the authors conclude by saying that tailoring anti-reflux surgery is not needed, as motility preoperatively did not correlate with dysphagia postoperatively, and that Toupet was a better operation because of lower risk of dysphagia and was as effective as Nissen in controlling reflux. So much so that after the study, the authors abandoned the Nissen completely and started performing only Toupet fundoplications. And then they did a follow-up study at 2 years to see if it still works. And as you can see, the patients still fairly satisfied, not as satisfied as at 4 months, but still fairly satisfied. In terms of post-op Demister scores, still remain normal for majority of the patients in both the arms, and still dysphagia continued to be somewhat of an issue with the Nissen patients compared to the Toupet patients. And essentially at 2-year follow-up, their findings and the recommendations did not change. So it worked for 2 years, but is it going to work longer as compared to Nissen fundoplication? So this is a randomized controlled trial out of Holland. And this is almost 10, 11-year follow-up. The only caveat being that these are all open fundoplications, both Nissen and Toupets. And in both the total and partial fundoplications, in terms of heartburn and regurgitation, almost 90% satisfaction for the patients and lack of symptoms. The dysphagia scores in this study were not different, even though Nissen patients did report a little bit more odynophagia. The sense of rectal flatus and postprandial fullness was higher in the Nissen cohort compared to the partial fundoplication in the Toupet cohort. But importantly, Toupet maintained high levels of reflux control even after 10 years. And so during this time, many more randomized controlled trials undertaken comparing Nissen to a Toupet. This is one meta-analysis published in British Journal of Surgery back in 2010. So variable number of patients, the partial wrap varied from 200 to 270 degrees. The bougie size varied significantly from 34 French bougie to 56. The wrap length was variable from 1.5 to 4 centimeters. And the follow-up, at least 1 year in all the studies, up to 5 years in one. So a lot of differences, a lot of variability, but within those differences, looking at Nissen and Toupets in terms of post-op pathological acid exposure and esophagitis, both cohorts are fairly comparable. Dysphagia, again, not surprisingly, higher for the Nissen compared to Toupet. The two highlighted studies, Kurian and Stretta, Kurian used a 34 French bougie, Stretta a 36. Kurian did not report more dysphagia, but Stretta did report more dysphagia with a smaller bougie. And then looking at the need for dilatation post-operatively, not surprisingly, patients who had Nissen required more dilatations. But satisfaction with both the operations was fairly high and exactly the same. The authors then report that Toupet fundoplication reduces dysphagia and the need for dilatation post-op. The reoperation rate and prevalence of gas bloat and gas-related symptoms was lower with Toupet, and they recommended Toupet as the operation for choice for gastroesophageal reflux disease. And this is a follow-up study from the one that I showed at 10 years, and this is again open fundoplications. This is now a 20-year follow-up, and then if we consider that the laparoscopic anti-reflux surgery started in the 90s, so that's about 25, 30 years ago, 20 years is a pretty long follow-up. Again, caveat being these are open fundoplications, not laparoscopic. And looking at patients who reported heartburn, this is at 11 years and this is at 18 years. And even at 18 years, both Nissen and Toupet doing really well. Regurgitation, both doing really well. Toupet slightly better maybe. In terms of gas bloat and flatulence, a little bit more of an issue with Nissen, not unexpectedly. And then flatulence was statistically significant compared to a Toupet. The ability to belch and to vomit, again, more maintained with the Toupet. than with the Nissen fundoplication. So the authors conclude that both the fundoplications worked really well in terms of acid reflux control, even at 2 years. The previously reported mechanical side effects of Nissen, they do improve with time. So this is a quick video. I think we did a great job discussing the technical aspects of Toupet a few weeks ago. This is a typical situation, large paraesophageal hernia, elderly lady. So this is about 5 years old. And since then, I have evolved, the technique has evolved. I do try to medialize the wrap a little bit more and hug the anterior vagus as much as possible, because the Toupet does get effaced a little bit after it's created. This is a picture I think Emily showed a few weeks ago. So this is the endoscopic view of a Nissen and Toupet fundoplication. Nice valve in both the operations. And looking at the picture, it would make sense that both the operation should work very well to control acid reflux. This is just a few more of the posterior fundoplications. What's missing from the list is a door. Door, as we all know, is used mostly in conjunction with a Heller myotomy and not necessarily as a standalone operation for gastroesophageal reflux disease. What about Lind fundoplication, which is also a 300-degree posterior wrap? Credit to Dr. James Lind, who was the SAGES president in 1985, utilized more in Europe than in US. So why I like the Toupet? I think it's comparable to a Nissen in terms of acid reflux control. The side effect profile is better. And I do not like the bougie too much because it's blind, and anything blind on the human body makes me a little nervous. So when to perform a Toupet, I think there's evidence to support its use as a standalone operation for GERD. Typically, older patients with large paraesophageal hernias get a Toupet in my hand. Younger folks who have GERD predominant symptoms, I think a loose floppy Nissen is still an excellent operation. And this has been discussed in the past, ineffective esophageal motility. Generally, once you see these values and they have preoperative dysphagia, they will get a Toupet, as we all know, in conjunction with the Heller myotomy. And again, if you don't want a bougie for any reason, severe esophageal strictures where bougie may cause a perforation might be a reasonable option. So last slide, this is a poll we did a few weeks ago, just looking at what folks are doing now, Nissen versus Toupets. So as you can see, number one is 90% Nissen, 10% Toupet, but number two is 30% Nissen, 70% Toupet. So I think Toupet has gained momentum. I think more and more people use it as a standalone operation for GERD, and I think that trend will possibly continue. Thank you, that is all I have. And next I will, let me look and see if we have any questions. We do have a few. So Ezra is asking if people affix Toupet the crura. So originally, Dr. Toupet did that. That's what he did. He would affix the wrap to the crura. And many people still do it. I do not do it. And just because I worry about having to go back and have to dissect all that out. But I think many people still, and this is again a poll we did a few weeks ago, most people still affix the wrap to the crura. So we'll keep taking more questions. Our next speaker is Emily Speer Heffner from Denver St. Jewish Health. She's a foregut surgeon. You may have heard already a few weeks ago.
Ruchir, I think.
Oh, I'm sorry. My bad. Alia is right. Next is Alia, not Emily. Dr. Alia Qureshi, she's a foregut surgeon from Beth Israel Deaconess Medical Center in Boston.
I think, I believe I was up next.
And she's going to talk about the Nissen-Hill operation. Alia, take it away.
Perfect. Thank you very much. And I will just take over the screen and this. Okay, great. And there we go. All right. Well, first of all, thank you everybody for tuning in, and thank you also to Dr. Puri and Drs. Andy Wright, also SAGES Foregut Facebook Collaborative for having this opportunity for us to get together and speak to you today. So this is the session Alternatives to the Nissen, and I will be speaking about the Nissen-Hill hybrid. So the story I'm going to tell you is essentially a truncated version of a larger talk, but I have the salient points, which is I know what all of you really want. And it's really entitled 3 Men and a Clinical Problem and the Solution that each of them come up with. So no surprise, the 3 surgeons I'm going to talk about, Dr. Rudolf Nissen, Dr. Lucius Hill, and Dr. Ralph A. So the Nissen, I do not need to talk, Dr. Puri gave a very nice detailed background to the Nissen, and many of us who do anti-reflux surgery are already familiar with it. I will say, however, that Dr. Nissen is a fascinating man to read about, and if you happen to find yourself with some time and opportunity to read, I would highly recommend the book called Nissen. So he created the 360-degree fundoplication that, as we saw, is most popular. Interestingly, when you read his original paper, he speaks in great detail about the difficulty, the many iterations he had in creating this. His original paper was actually published in 1956. He then revised it and made it better, and we all know what that's about, and published it in 1961. He was ridiculed and there was a lot of pushback, no surprise. And then he actually, it was not accepted until the 1970s. In his original paper though, one aspect that I found very interesting is that he spoke of the Nissen fundoplication as a adjunct to abdominal pexy of the lesser curve intra-abdominally. And I did not know that until I actually went back to his original paper. So a lot of us have been trained in the Nissen, and of course it's a fabulous operation. It is very robust. Many of us use it for many different indications, including sometimes with compromised motility. However, it has its drawbacks. Those drawbacks include dysphagia of the 360 wrap as well as herniation. And here are 4 patterns of herniation that I won't go into detail, as many of us are all too familiar with those. The second surgeon I'm going to speak about is Dr. Lucius Hill. Now, you may not know as much about Dr. Hill or his repair as you do about the Nissen. So Dr. Hill, in 1967, published his landmark paper, 8 years of the procedure that he created. And the Hill repair essentially was his attempt at recreating the structural integrity and anatomy of the native gastroesophageal valve. And the way he figured this out was by essentially doing 100 cadavers at just quite similar to Dr. Toupet, as Dr. Puri was talking about in his talk. So Dr. Hill felt that the only way to treat reflux disease was to really truly recreate the angle of His and recreate the anatomy of the gastroesophageal valve. So his original paper published the results of his 149 Hill procedures. These are all open procedures, and it essentially involves taking the anterior and posterior phrenosophageal bundles, and I'll show them to you in a slightly better picture. On the bottom right, you can see that cartoon or drawing of the bundles being brought down to the median arcuate line. And the other, perhaps more challenging component of this repair is that intraoperatively you do manometry. So anesthesia would put down a catheter, usually a pulmonary catheter, and then you would gauge and calibrate intraoperatively your lower esophageal sphincter to the pressures that you would desire. And this was later modified by Dr. A and Ralph A to be a laparoscopic version of the same repair. And when I was a fellow, we did these operations, and you knew when it was, we would have Fundo Fridays, which were 5 fundoplications on Friday, however long it took. And we would basically, as we would do the Hill repair, we would put in our sutures, essentially 4 Hill sutures through on the anterior side, the phrenosophageal bundles, 1, 2, 3, 4. And please let me know if my signal is unstable. coming across. So I'll continue. So 4 sutures were placed, and then it was tethered down to the arcuate ligament as shown here. An intraoperative manometry was formed. Essentially, the surgeon would go down to the other, to where anesthesia is, put down a pulmonary catheter, and again, gauge those pressures. So it was quite meticulous. It required you to be meticulous in every sense, and then you'd have to come back and play with your sutures. So no surprise, there were many critics of the Hill repair. People spoke about the inconsistency of the pre-aortic fascia. The phrenosophageal bundles were not so quite easy to see, and I'll show you video in a little bit. And then, of course, there was risk to the celiac artery as well as the aorta. The final, perhaps most major criticism was that only Dr. Hill got good results. So I've briefly spoken, and you heard also Dr. Puri speak of the Nissen and the Hill. Long-term outcomes for each of the repairs are actually quite good. 90% success with the Nissen in long-term follow-up, and the Hill at 25-year outcomes, 93% symptom control. However, both procedures had a failure rate around 7%, and in the Nissen, 7 to 10%. So Dr. Hill, Dr. A, very much like Drs. Nissen and Hill, keen observer, innovator, he analyzed the failures. So he performed, along with the Oregon group, Dr. Swanstrom's group, Dr. A, and our group performed a randomized multi-institution comparison of the laparoscopic Nissen and Hill. And when he compared them, he studied the failures. And he hypothesized, when you think about the Nissen, the major, let's say, recurrence issue is the intrathoracic herniation. And he hypothesized, if you look on the left diagram, that the net intra-abdominal, or the net force is essentially pushing the Nissen up into the chest. There's 3 forces: the intrathoracic negative force, the very dynamic force of the diaphragm as it springs with every breath, and then of course the positive intra-abdominal force. So the net pressure pushes the Nissen into the chest. However, quite different, Hill in this particular study had 2 failures, the Hill procedure. And those were not due to that factor, but in fact, they were due to loosening of the Hill sutures. So he thought there was a real opportunity here, and that you could create, and what he called in his mind, the ideal repair, if you could combine the integrity of the Nissen, and you could combine it with the intra-abdominal fixation of the gastroesophageal valve of the Hill, that you could potentially offset the inherent weaknesses of each repair. So essentially, the 2 repairs would complement each other. So he designed the repair and piloted a study. So here on the left screen, you have the untied hybrid repair. And what you have on the bottom of the left figure, you have the 2 Hill sutures, the distal and proximal, and then on top of it, still not yet tied, is the Nissen fundoplication, as you would normally perform it with all the rigors. So the idea, and sorry, on the right panel, you have the actual sutures tied down. So that's actually what it looks like when you do it intraoperatively. So the Hill sutures would keep the Nissen from herniating, and the Nissen wrap would actually keep the Hill sutures from loosening. And that's the theory behind it. The actual creation of this operation intraoperatively is slightly complex, I would say. You have to do it in sequence, and it's important to do it in sequence. Thank God there is not intraoperative manometry, which is a big positive, I can tell you. And the steps are the Nissen configuration, then placement of the Hill sutures, then you actually go back and construct the Nissen, and you complete your Hill sutures, you tie them down. And during these steps, it's really important to tuck away your Hill's, the actual suture, so that you can construct your Nissen, and that's important. And here I'm going to demonstrate for you video. Let me turn that down. Okay, so here we've dissected the esophagus. We've done a high mediastinal dissection, and we've reduced the esophagus into the abdomen, and we've closed the hiatus. Now, as we, the first part really is configuring the Nissen, but not tying it down. So I'm going to go to where we start configuring the Nissen, and placing our stay suture to bring that around. And then I'm going to take you next to the actual configuration where I do the shoe shine. And then we're kind of happy. Okay, we've configured our Nissen. The next step, of course, is to, once we're pleased with that, then we move on to place our Hill sutures. So this is the part that may be unfamiliar to you. And I'm going to navigate to where we start placing our, we start looking at the gastroesophageal valve and thinking about where we're going to place our distal anterior suture in the anterior phrenosophageal bundle. And it's a robust bite, and it goes right through. And once we have our anterior suture placed, then we go on to the posterior distal suture, and that's the second part. And I'll take you to that. And apologies, in the interest of time, we won't watch all the in-between stuff. So that's the posterior suture. And now I pull that through, and now we're going to go to the median arcuate ligament. We've already exposed it during our dissection in preparation for this. And what you want to do is take a really nice robust bite, and you hold that up, and that prevents you from actually doing something bad. And again, it's a nice robust bite through that tissue. So once that's done, then you pull that through very carefully. It's an O-ethibond that's being used. You brace it, you pull that through, and then you tie it and tuck it away in the right upper quadrant. And then you're ready for your next suture. And I'll just go through that a little bit more quickly in the interest of time. And here we go. Here's the second, the more proximal suture, parallel in the anterior. It will be parallel in the posterior suture as well. And then right to the, I'll just take you to the actual arcuate ligament. And you use your first suture, of course, to help you lift that tissue and expose it for yourself. Nice, robust bite. And again, you pull it through and you tuck it. And these are kind of the nuances I was talking about. So you pull that carefully through, you brace it, and then you tuck it away in preparation now for your Nissen completion, which we, as you know, we already configured it. And now we're going to get ready to actually make the Nissen. And I'll take you right to that point. So this is a horizontal mattress that's placed through the Nissen. And we're just coming up. And I use a 2-O-proline. This is pleated. This is the main horizontal mattress. And it bites through the esophagus, as you can see. I kind of raced through that just in the interest of time. And now we will suture that down. That's the tie knot device, which I happen to love. It gives great, excellent knots, actually, in difficult positions. And then we place 2 simple sutures above and below. And then we're actually going to go to the actual, we take out the Penrose, and we'll go to now tying down the Hill sutures. And those are all set up for us. We tuck them away. Now we pull them out of the abdomen so we can tie them down with the tie knot device. And just setting ourselves up, I typically will do the proximal one first. There are different colors, again, a nuance, so you can tell which suture is which easily. And now you're going to just suture them down to the tie them down to the arcuate ligament. You're fixating the gastroesophageal valve. The inferior suture is actually pleated. And so what you've done is you basically protected the Nissen wrap from herniating with the anchoring of the gastroesophageal valve. And you've also protected loosening of the Hill sutures by essentially placing a fundoplication on top of it. And that's essentially what it looks like once you're done. And we'll just place that down. The hiatus is still pretty open, and then we go on to close the hiatus with a couple of simple anterior sutures, and that's essentially that, and that is the hybrid procedure. So of course, after that, we went on to study it briefly. I won't go into much detail. The first study, which I was the lead on, was that of patients who had difficult GERD, paraesophageal hernias, and Barrett's esophagus. That was the pilot. We then went on to do 50 patients in the next series, and since then there have been over 900 hybrid procedures that have been performed. And the results have actually been quite good. Dr. A and Dr. Louie and their group have done comparisons between the laparoscopic Nissen, the Hill, and the hybrid, and the results have been actually quite excellent in terms of anatomic recurrences. They have been lower for the hybrid than for the Nissen. And then the side effect profile, which was obviously the other concern, with such a robust repair, we were quite concerned that the side effect profile, in particular the dysphagia, would be worse. But in fact, somewhat counterintuitive, the Swallow survey actually demonstrates that it is improved for the hybrid when compared to the Nissen or the Hill repairs. So Hill sutures can also be used in combination with other wraps, and I've heard that Dr. Louie is now doing a hemi-hybrid, so just doing one Hill suture. I think the important point, whether you do the Hill repair or the hybrid or Hill suture, it is important to remember it is the only repair that truly anchors the fundoplication to the gastroesophageal valve to the pre-aortic fascia and anchoring it intra-abdominally. And when you use just a Hill suture, you do not need to do intraoperative manometry. Are there other roles for the hybrid? Absolutely. There are papers currently in the works by Dr. A and Dr. Louie's group, a paper in the works for the short esophagus, comparing it to the Collis Nissen, as well as you can imagine Hill sutures would be extremely helpful in patients post-bariatric surgery because you do not require the fundus. You can just place Hill sutures. And this is a paper by another author, Guerrero, in 2017, and others are also working on similar to demonstrate to look at the effect of Hill sutures on post-bariatric patients. So with that, I do hope that I've given you the nuances and the theory behind the Nissen-Hill hybrid, and I thank you very much for listening and the opportunity. And I believe it is now Dr. Spears who is speaking next. Dr. Puri, I will give this back to you.
So
I have lost, here we go.
Before you start, Emily, thank you, Dr. Qureshi. That was fantastic. I think I've read about the Nissen-Hill multiple times, but probably the first time it kind of makes sense to me. I still don't think I'm ready to do it tomorrow, but it does make more sense. So that was a fantastic talk. And apologies again, Dr. Qureshi and Dr. Speer, for jumping the gun and messing up the order of the talks. One question on Facebook, Dr. Qureshi, is, this is from Dr. Fahim Habib, thoughts on a hybrid when you combine a Hill with a Toupet to reduce post-op dysphagia. So instead of a Nissen-Hill, a Toupet Hill.
That's an extremely interesting question. And of course, anything is possible. You would have to study it. And you would have to anatomically look at how you would place the Hill sutures. But in theory, of course, it's doable. I think it's a really interesting idea. If you're concerned about dysphagia, you know, the evidence shows that in Dr. A and Dr. Louie's work that there's less dysphagia in the hybrid than there is in the actual Nissen or the Hill by themselves. So I think you'd have to be very thoughtful about studying it and then actually plan it, design an operation and then test it out. But fabulous idea.
All right, thank you, Dr. Qureshi. All right, so next is Dr. Emily Speer Heffner from Denver. And you may know Dr. Heffner already because she gave a talk a couple of weeks ago on techniques of Nissen. So with that, I'll let Dr. Heffner get started with her talk.
All right, I'm Emily Speer. Those were great talks, hard to follow. Nice work, Dr. Qureshi and Dr. Puri. So today I'm going to be talking about LINX fundoplication or magnetic sphincter augmentation. I'm going to stop my video so that hopefully my other videos will play a little bit better. All right. So magnetic sphincter augmentation. I have no disclosures except I'm about ready to name drop LINX a lot because it's one syllable and magnetic sphincter augmentation is a lot more. I want to talk about the background. If you don't have LINX, how you can negotiate with administration to get LINX at your hospital, some billing nuances, preoperative decision making, some intraoperative techniques, tips and tricks, and some postoperative considerations. So the LINX is a neodymium iron boron magnetic core that's coated with titanium and exerts about 15 to 20 millimeters of mercury on the lower esophageal sphincter. And it was officially approved for use in 2012. And since that time, the data has shown nice reduction in GERD HRQL scores, PPI cessation, esophageal acid exposure percent times, as is nicely outlined in these tables from a review article. There was a nice prospective multi-institutional study reporting 5-year data with 100 patients enrolled, and they followed 85 of them to 5 years and found that 84.7% were off their daily PPIs at 5 years. And their 1-year data had some nice reduction in percent times and Demeester scores to normal. And in this study, they had no erosions, but in a bigger subsequent study of over 3,000 patients over 4 years, the erosion risk was about 0.15%, which is about what I quote my patients now. There was a nice study by Dr. Lipham's group with 100 patients who underwent a matched pair analysis of LINX versus Nissen. They had similar GERD HRQL scores at 1 year, but no difference in mild gas bloat, but a big difference in severe gas bloat at 1 year, with 10% with Nissen and 0% with MSA. There are some contraindications to LINX, of course, metal allergies, the need for MRIs, which could demagnetize them. One of my own personal contraindications for LINX is if they're TCFL, so if they have anxiety or supratentorial symptoms, they will not do well with a metal implant around their esophagus, and they will name it, feel it, it'll interfere with fertility. Don't make the same mistake I did. The precautions with the tildes next to them are precautions that are either have gone away or are slowly changing, such as hiatal hernias greater than 3 centimeters, which I'll talk about, Barrett's esophagus, which I'll talk about, prior foregut surgery. I've done a couple of patients who are redos and they were candidates for LINX. I always have fundoplication as a backup, of course, but they've done very well, as well as motility. We'll talk about that. So there were a couple of studies that showed the safety of LINX with hiatal hernias greater than 3 centimeters, as well as relatively low recurrence rates. And this was thought to be due to the preserved ability to belch and therefore less gas bloat and less axial tension on your repair. This is a study of 86 people with non-dysplastic Barrett's who underwent LINX. And there was actually 71.6% regression at 1.2 years. And 0% progression to dysplasia or carcinoma. There are pros and cons to LINX. One of the pros is that it's a pretty easy postoperative diet with later dysphagia. There's less nausea, so it lends itself really nicely to outpatient surgery. There's less severe gas bloat. Herniation may be lower risk and may be less symptomatic as well. When you have a fundoplication smushed up in your chest, it tends to be much more symptomatic from an egg juice standpoint than the LINX device. But the cons are, again, erosion, which looks like it's about 0.15% risk. The device can be demagnetized, it can be defective, and the prior authorization process can be lengthy. When negotiating with administration, like all of these therapies being discussed today, this is just one of the many pieces of a comprehensive foregut program, and it does bring in more referrals. For every 3 LINX referrals I get, I probably get 1 that's a candidate for LINX, and then the other 2 get fundos. And along with those referrals come increased profit for the hospital from pre-op testing like pH, mano, upper GI, EGDs. It is an outpatient surgery, shorter OR times. One of the things that you'll want to negotiate is a cash pay option, which in general usually is somewhere around $12,000 to $14,000. And one of the things that you'll be up against is that LINX itself costs about $5,000 for the device alone. But this was a nice study by Lipham's group that looked at the total charges of Nissen versus LINX. And despite the $5,000 device cost, there was no significant difference in charges due to the lower length of stay, OR time, radiology studies, room and board, etc. So another nice study to show your admin if you're considering getting LINX. So billing can be a little bit of a challenge. The CPT code for links is 43284, but this is a code that was created in the era of the minimal dissection technique and was described for hiatal hernias less than 3 centimeters. So what to do for patients with larger hernias is currently unknown. Often surgeons will bill a 43281 for any paraesophageal hernia or hiatal hernia greater than 5 centimeters, because if you read the AMA clinical vignette for 43281, it's often the closest, most accurate description of the procedure you're performing. It does pay a lot better than 43284, so it will usually cover the cost of the links. Even with Medicare or Medicaid, you can usually break even. If you bill a 43284, you will usually be going through the prior auth service PRIA, which can take up to 3 months as well. So things to kind of keep in mind with billing. I generally do the whole gamut when it comes to preoperative testing because I like to know exactly what I'm dealing with up front, and it makes the PRIA process much smoother. Previously, we would only implant links in people with normal manometry, but as you know, the cutoff has changed from 70% peristalsis to now 50% peristalsis being considered normal. So that 50 to 70% normal peristalsis population is in a little bit of a gray zone. And so if I'm ever unsure if a patient will tolerate links and they really want it, I'll often repeat manometry, throwing the kitchen sink at them, which is, PPIs, H2 blockers, Carafate, just throwing everything at them to heal that esophagus up and give them the best motility possible. And if they do not want to repeat manometry, understandably, I'll often put them, just give them a marshmallow bagel swallow study. Port placement, I operate from the patient's left side. It's great visualization, easy to see way up in the hiatus, and I go higher than my fundoplication ports because you won't be taking down the short gastrics. Again, because you're not taking down the short gastrics, that left crural dissection there is a little more minimal than you would normally have for a traditional fundoplication. We rarely do the minimal dissection technique anymore because we were putting links devices around people's stomachs accidentally. So now a circumferential dissection is what's recommended if there's any concern whatsoever that a patient may have a hernia. I just fix the hernia like I do for a normal fundoplication, going up tight against the esophagus, but not too tight, just so I can fit an instrument between the esophagus and the hiatus there. And after I fix the hernia, then I create a retroesophageal window behind the esophagus and that posterior vagus there, right at the GE junction. And I'll slip a little 1/4 inch Penrose through there. And that Penrose device, or that Penrose, will hold the tract there for me and will allow me to insert the sizing device and then ultimately the links device through that same nice tract, and it kind of acts as a slip and slide, so it goes really nicely there. So this sizing device, that metal part, it goes right up against the esophagus, and then you advance that little white tube there that has a magnet at the end of it. And what you can't see is that on the outside of the body, as I'm tightening up this device, it's actually measuring what size of links device you want to implant. And as you're slowly tightening it, you're looking at the size of the device, you're looking at how tight this is around the esophagus, and you don't want any compression. Once it pops off like that, we used to say add 2 sizes, so measure what size the device was measuring at, and then add 2, but now we actually add 3. So it pops off right there. Go back in that retroesophageal window, grab your links device, and then pull it through. And then what I like to do is grab that white string, kind of pull it down to the bottom right of the screen, and then grab the green string and try to bring it to that white string. It helps it line up nicely. That was not a trick that I made up. It was created by somebody else. And then in this video, I truly am just trying to keep it honest. It can sometimes be a little tricky to line up these clasps here. But once you do get them lined up, then you just chomp it a little bit, pull at the strings. I can see that it's actually not quite clasped, so I'm gonna chomp it closed a little bit further. And now I can see that it's clasped. So I go ahead and cut off those strings and remove the penrose. And you can see just how loose that device is around that lower esophageal sphincter. It just lays there nice and loose like a necklace instead of, not like a choker, but loose like a necklace there. Endoscopically, you can see that with the stomach fully insufflated there, it's still a really nice Hill grade 1 valve there, nice and tight, despite the Lynx device being pretty loose. Intraoperative EGD, this is the difference between a Nissen and a Lynx. And then postoperatively, so this is an outpatient surgery. Day 0, patients eat soft foods. And then from day 1 to week 8 is esophageal physical therapy, which is the most important part. Patients eat a regular solid foods, a couple bites every 1 to 2 hours. And they usually notice that from weeks 1 to 2, that's their honeymoon stage where everything is perfect, they feel great. And then weeks 3 through 8 is that dysphagia curve where they start having more difficulty swallowing. And that's the time that that capsule is really forming and scarring down, and they need to hammer down on that esophageal physical therapy to keep that capsule loose. And I always tell patients, what you put into this over the next 8 weeks is what you're going to get out of it. Occasionally, this is often due to non-compliance with the esophageal physical therapy, but you can have an aggressive capsule formation. And so if patients have persistent dysphagia over 3 months, I'll often do a fluoroscopy guided balloon dilation, where you watch the beads open as you're dilating them with a 50-50 contrast mix, followed by a 5-day burst of prednisone, and then the Lynx diet over again. 1-year testing, I like to get pH and manometry on everybody just to follow my outcomes. And then if they had a paraesophageal hernia, I'll often get an upper GI as well. And this is a neat video of a solid bolus going through the Lynx device, and you can see about 2 to 3 beads open, and then it just remains closed and loose the rest of the time. Final thoughts. Same thing I always say, but I love these famous words of Lee Swanstrom: if you break it, you own it. Of course, we all want our patients to have perfect outcomes every time, but when you have patients that aren't 100% satisfied, just remember that you, not the GIs, not the PCPs, are the most qualified person to manage those problems and make the patients feel better. Thanks so much for allowing me to present today. Let me go ahead and...
Emily, that was fantastic. And you just made my day with the esophageal physical therapy. The esophageal physical therapy really did it for me. That was fantastic. Now we have a couple of questions. This is Dr. Kevin L. Hayek. He's asking, well, if the patient doesn't have a hiatal hernia, then how do you bill for the Lynx?
So I think a hiatal hernia is really easy to miss, and that was one of the problems in the era of the minimal dissection technique, is that you could really miss a very subtle hernia, and you would notice it because you would be sizing your Lynx device at a really high size, like 19, 20, which they don't even make devices that big anymore. So I pretty much routinely always dissect out the crura and close the crura to make sure that that doesn't happen, because the Lynx around the stomach just does not work.
Now, one thing I think, because when I initially saw this many years ago, we were just putting it around the G junction, right? We were not really dissecting into the esophagus. We weren't really getting esophageal length. So is it fair to say that after you obtain esophageal length, I mean, there's almost always going to be a hiatal hernia, big or large?
Exactly, exactly.
All right, and the second question, Dr. Andy Wright, any insight into the corporate changes at Lynx and whether that bodes any changes in product availability, support, etc.?
Yeah, there is way less support, and I have definitely noticed that, which is such a bummer. I think that when you're trying to bring Lynx to your hospital, not having reps there teaching you what other surgeons are doing around the country and around town, that is just a huge problem. I've searched high and low and asked why this is happening. Maybe somebody out there knows why they pretty much withdrew all of the support from us. But I think that's going to be a huge challenge if you want to bring Lynx to your hospital, is it's just not really having good support.
Okay. And one more question from Amber Shara, and I think Andy mentioned briefly also. So 3 sizes up, that's the new norm, not 2.
3 is the new 2.
3 is the new 2. Excellent, excellent. All right. Thank you, Dr. Speer. And next we have Dr. Kevin Reavis. He is from the Organ Clinic. He is a foregut and bariatric surgeon, and he's going to talk about the transoral incisionless fundoplication. Dr. Reavis.
Great. Can you see me?
Yes.
All right. Are my slides up?
Not yet.
Okay. Oh, here we are.
Share screen.
This should do it. How about that?
Yes, we can see you. We can see the slide.
Great. Well, thanks for the invitation, and I'm happy to talk about endoscopic alternatives to fundoplication, in this case, transoral incisionless fundoplication. I have no disclosures really over the last 12 months, but I have done some consulting work with Endogastric Solutions, the maker of the esophagus device, which is what is used to perform this operation in the past. So briefly, we're going to frame the challenges of treating reflux disease and then move quickly on to the specifics of this talk, being transoral incisionless fundoplication, indications, the technique, the outcomes, and its also evolving role. So one of the issues with treating reflux disease is the long-term issues with medications. They have costs, they have side effects. The flip side is that surgery on the other end of the spectrum is pretty intimidating, and there are patients who are dissatisfied with these kind of bimodal options. So there's definitely a patient subset that's okay with relative improvement of their symptoms, but not necessarily mandating complete resolution of the disease process. As you can see on this slide, reflux is a spectrum. You've got mild disease, which can be well managed with medications. You've got severe reflux, paraesophageal hernia type problems, which absolutely require surgical reconstruction. And there's this chasm in between, which is for the most part been poorly addressed in terms of, again, patients that don't necessarily fit into one box or the other in terms of disease severity. So the work I've just kind of described with our other speakers involves your classic endoscopy, looking for basically a patulous valve between the esophagus and stomach, an esophagram demonstrating a wide open lower esophageal sphincter, freely allowing gastric regurgitation into the esophagus, and then esophageal or pharyngeal pH testing plus or minus impedance. This is a ResTech study here. With the pH dropping and demonstrating regurgitation all the way up into the pharynx. Then finally, compliance, motility testing of the esophagus, possibly also the stomach to make sure that you don't have gastroparesis. Again, typical topogram of high resolution manometry, and then endoflip imaging over here with esophageal compliance. You don't necessarily need all these tests. However, certainly enough to objectively be able to diagnose the patient and determine what their best treatment option is. So in my quiver of various reflux treatments, transoral incisionless fundoplication falls neatly in the middle between medication for those mild disease patients all the way up to the most severe cases requiring hernia repair plus fundoplication, or Hill procedure, as Alia nicely described, or even bypass gastric diversion type operations as needed, and then a number of potential endoscopic and laparoscopic options in between. So the device, the esophagus device, has made several iterations over the last decade and has become much, much more streamlined in terms of its utilization and replicatability, which is fantastic for us. The idea is that you have this tissue mold, appears more like a lobster tail, that folds the esophagus and stomach together and then fires these H fasteners to create a valve or fundoplication, really cardioplasty, almost again like a Hill repair of the esophagogastric junction. The idea is to create a 270-degree, 2 to 3 centimeter long omega loop or omega shaped wrap of the esophagogastric junction. So inclusion for this type of treatment, amongst other inclusion criteria, the patients obviously have to have objective evidence of reflux disease for greater than a year. Ideally, no hiatal hernia for an index incisionless fundoplication. In my case, that's what I really look for. There are some evolving rules for TIF, which we'll get into in a bit. Then also, again, proven gastroesophageal reflux disease by either endoscopic findings, ambulatory pH is the gold standard, or barium swallow testing. Now, exclusion criteria, this is not ideal in patients who have morbid obesity. Those are the giant hernia. However, in 2017, this was approved for use in concomitant repair of hiatal hernia with immediate fundoplication with the esophagus device. Esophagitis grades that are basically horrible, severe reflux disease with prolonged or long segment Barrett's esophagus, and other conditions in which you really wouldn't want to be firing fasteners through the esophagogastric junction, portal hypertension, cirrhosis, gastroparesis because you're inadequately treating the gastroparesis portion of the patient's GI problems, and connective tissue disorders, and essentially anatomic issues where you wouldn't be able to place the device, strictures, Turner syndrome, again, some situation that was a non-starter. This is just a quick animation of how the device is placed. This is the newest iteration of the esophagus device and the kind of endpoint goal. A high definition endoscope is now compatible inside of the device, so it kind of slides as an over tube after dilating the esophagus down into the stomach. The scope is retroflexed, as is the device itself. A little helical retractor is placed into the esophagogastric junction and the tissue retracted into the device itself. The fasteners are deployed after the invaginator extends the esophagus as best down through the hiatus as possible. And 2 fasteners are fired at a time with a essential squeeze of the trigger, which I'll demonstrate in a real video here in a moment. You can fire basically as many fasteners as you like. The cartridge comes with 20. There's certainly reports of 20 to 30 fasteners being utilized to essentially quilt this fundoplication in place. My most recent video is pretty dark. So Ken Chang at UC Irvine was nice enough to share with me a recorded video, which we shortened down to 3 minutes for the audience purposes today, in which case the device is placed. You can see the endoscope kind of scouting the way down into the stomach with the device coming in over that scope. There's the pylorus. You then retroflex. You can appreciate the device coming through the esophagogastric junction into the stomach. Once you see the blue and gray portions of the device itself, it's now safe to pull the scope back into the device and then basically fold it so that it now retroflex into the esophagogastric region. The scope is now essentially an observer as the device is used. You can appreciate here the gastric cardia and proximal funduses folded into the groove, and the fasteners are basically loaded and then fired initially at kind of the 10-11 o'clock position of the view. And then this is replicated again at the kind of 1 and 2 o'clock position, as you can see Ken rotating the device around. As you can appreciate on the left screen as well, this is a bit of a dance with your fellow or assistant. I think my former fellow Chirag Dalakia is in the audience today, and he remembers the 2 of us in each other's personal space, as one was on the device, the other was on the scope, and we had to again be comfortable with that physicality as we're able to proceed with the operation itself. But you can see the folding of the stomach around the device here, creating a nice omega loop, very similar to a surgical fundoplication, essentially being constructed endoscopically. Kind of move forward just a little bit for the sake of time as he finishes. A couple of fasteners being deployed at the 5-6 o'clock position and releasing the helical retractor there. As you can see, the fundoplication looks very similar to that of a surgical fundoplication at this point. The device is then straightened out after kind of reviewing the work and removed, and now the endoscope is going to be removed as well. He's kind of checking to make sure there's no transmural injuries. And as he pulls the device back, he appreciates that the valve is snug. But it's also nice, as you can appreciate the full thickness fasteners. As he pulls back here, look at the 6 o'clock position. You can see 2 fasteners there kind of in view. Many of them are tucked away in the mucosa, but it demonstrates, again, the complete plication. Usually you'll see those fasteners up as high as 2 to 3 centimeters above the squamocolumnar junction, demonstrating the complete imbrication and fastening of the tissue. Here's from Reg Bell, just demonstrating the laparoscopic and endoscopic view of the gastric cardia and fundoplication being performed. So you can see here again the proximal fundus being brought across the esophagogastric junction and tucking a little bit of the esophagogastric fat pad in there as well. But again, showing how this essentially matches that of a surgical fundoplication without obvious taking down of the short gastric vascular pedicles. So what does it look like? So this is a recent publication in GIE showing normal baseline high pressure zone of the lower esophageal sphincter with the manometric topography. Again, baseline reflux, this is fairly lax. The earlier iterations of this procedure kind of mishit the exact target, and I've gotten very close to it now with TIF 2.0, and maybe even more physiologically accurate, as Alia was alluding to with Hill gastroplasty compared to Nissen, which may be a little super physiologic. It certainly takes care of the problem and may overdo it just a little bit, resulting in some of that side effect profile of dysphagia, bloat, etc. So historical comparisons, it does a good job, as you can see in the top data in terms of the TIF and hiatal hernia repair plus TIF. Subjectively getting patient off meds and esophagitis being healing is very effective, consistent with that of anti-reflux surgery or ARS. Now, again, probably compared to a complete fundoplication, which is going to demonstrate greater than 90% normalization of pH, the TIF is not quite there. However, it does a really good job, quite similar to that of partial fundoplication. And again, remember the patient target here is oftentimes patients with modest disease, not necessarily the severe disease, but modest disease, who simply would not like to have to undergo a formal surgical procedure if they can avoid it. And then finally, the side effect profile, as expected, if you're not exactly hitting pH targets every time, hopefully you're preserving some of the anatomy and physiology that patients dread or alleviate the concerns that they dread, that being dysphagia, bloat, etc., that is sometimes seen with complete fundoplications. So it is certainly reported a bit less with the endoscopic approach. However, these are variable groups, and so that is not absolute gospel at this stage. But again, trends that are somewhat encouraging. I'm going to quickly touch on the two main randomized clinical trials. The RESPECT trial, which I was a part of several years ago, was a multi-center crossover trial comparing TIF versus PPIs, and the TEMPO trial, which was subjective endpoints and is now 5 years out in terms of follow-up. The RESPECT trial, what we found is that in the TIF patients, that their Denister scores or pH scores drop substantially and significantly, but not necessarily to less than normal, sorry, not below the normal threshold in many cases, but the satisfaction scores were very high compared to obviously patients with PPIs. When they halted their PPIs, their reflux disease remained unchanged, which is what you hope to see in your sham group. Now, the TEMPO trial looked at GERD, health-related quality of life questionnaires over the course of 1 to 5 years, and you can see substantial improvement, and these maintain at 5 years. And in case series now, this is also seen to carry out at 10 years. So there is some durability, as you can see in the photographs at the bottom, with a preoperative, immediate postoperative, and 5-year follow-up. So the procedures, particularly in well-selected patients, which I'll get to in a SAGES guideline statement, seems to hold up. How about where are we going now? So TIF, is it appropriate in a revisional patient? For example, after a fundoplication that's loosened and you really don't want to have to go back and redo the surgical fundoplication because those are challenging. Reg Bell in 2013 published a small series of 6 patients, and 5 or 6 of those had normalized pH. In my own personal experience, I had a patient who had a TIF and a couple years later said, I have heartburn. We tested him. He did not have abnormal acid exposure, but a year after that he did. I asked if he wanted me to convert him to fundoplication. He said, no, I want a tune-up. So we tuned him up with another TIF, and he's done great thereafter. How about after peroral endoscopic myotomy or POEM? This was recently written up in the European side of things, and they found that in a small series, 5 out of 5 patients were free of PPI dependence after the procedure. This was done about 3 months after their initial endoscopic myotomies, and essentially mimic the fundoplication that we may do after Heller myotomy for achalasia. There's been a couple case reports of doing POEM immediately alongside of a TIF, and I would consider this hazardous at this stage and probably unnecessary. given the fact that if you do the procedure before the poem, you're going to have to dodge the fasteners on the way down doing the endoscopic myotomy. And if you do it immediately after the poem, you are now dealing with fresh mucosa that either has a large mucosotomy or hole in it, in which case the device could shred that, or you have clips in place, which again also provides a serious roadblock. And given that less than half of patients who undergo endoscopic myotomy develop severe reflux disease in the long term, this portion of the operation is probably unnecessary in the majority of patients undergoing myotomy. So it's probably best to allow folks to heal up and then survey them closely as we do our patients after myotomy long-term and see if they need additional treatment, either surgical or endoscopic fundoplication at a later date. You may have also heard of C-TIF or cruriplasty and TIF. So as I mentioned in 2017, there's approval for TIF to be done in patients with hernias as long as they had a laparoscopic repair of the hernia followed by concomitant fundoplication. And I would say, again, this is my personal opinion, compared to surgical hiatal hernia and repair with either partial or complete fundoplication or Hill gastroplasty, the Pro is quite reproducible. This device, particularly the latest iterations, makes this about as easy as firing a swing line stapler compared to the device back when I started in 2008, which took a serious amount of artistry to complete the procedure. The con is that you've got an increased amount of resource utilization. Each of these devices is a disposable device costing several $1,000s, and you simply need to come into consideration of that. Again, there is something to be said, though, for the reproducibility of this versus the artistry required for surgical fundoplication in most surgeons' hands. So the SAGES guideline, how does this measure up? Pretty substantial thumbs up. The conclusion basically is that TIF can be performed with an acceptable safety risk in appropriately selected patients. Again, folks that meet the criteria that I kind of mentioned at the beginning, and we'll recap here at the end. The level of evidence was strong in terms of, again, it's appropriate in appropriate patients. In conclusion, I think that it's best, like all of our reflux patients, to treat their candidacy based on objective data. You really need to take into consideration their expectations. What are their hopes? What are their fears? What are they willing to accept? They want to avoid surgery. Are they okay with mild antacid medication as long as they can be off of PPIs, that type of thing? And with that, you can provide an optimal tailored treatment. So with that, thank you for your time.
So Reavis, thank you. That was a great talk. And there's been some buzz on the Facebook regarding, well, two main things. One is combining laparoscopic hiatal hernia repair and the TIF procedure. And I know you touched upon it briefly. If we take the cost of the device aside, if somebody had a significant hiatal hernia, would you try to combine the two, or we just do a fundoplication or a links or something of that sort?
I mean, I have a discussion with them. I mean, my default has been with that real world circumstance in mind of the costs. And so my default has been repairing the hernia and the formal surgical fundoplication. I think taking that out of the equation, it's a great fundoplication as you saw there. There is certainly a push by individuals who do not have surgical privileges, that being our gastroenterology colleagues, in which case this would be a great thing because that's where their wheelhouse stops in terms of clinical offerings, whereas a surgeon would need to be available if a fundoplication was needed or obviously some type of gastric injury. You don't have to take down the short gastrics as you probably would in most formal surgical fundoplications. There may be an advantage there. In the few endoscopic fundoplications that I have revised, they were fairly straightforward. There certainly are reports of nightmarish revisions, but for the most part, revising a TIF to a surgical fundoplication has usually been fairly straightforward. And so from that perspective, I think trying to avoid making life harder for yourself later with a revision, doing a hernia repair with endoscopic fundoplication would make sense.
And the second question is exactly that from Dr. Andy Wright. Any tips for take back or redos after TIF?
So the main thing is, and most folks are not aware when they do the procedure, is what happened with the diaphragm. So if fasteners penetrate the diaphragm, there's certainly the risk of an esophagopleural fistula. Some mediastinal abscesses and such were reported in the early stages with this. So the tips in terms of take back is that, if you see the blue fasteners, and they're usually fairly, present even within the scar tissue, snip those, they come apart pretty easily. But the revision is certainly, again, usually more straightforward than that of a Nissen fundoplication, and particularly as I saw Andy's comments earlier on the stream, a Hill revision is even more challenging, and I agree, not for the faint of heart. So again, clip the fasteners, and otherwise, again, it's fairly straightforward.
Thank you, Dr. Reavis. And our next speaker is Dr. Ashwin Kurian. He's got a very busy Foregut practice in Denver, and he's going to talk about the Stretta procedure. Dr. Kurian.
Hey, thanks, Ruchir. Thanks to the SAGES Foregut collaborative to make this thing happen for us. Hold on, I'm just logging in. Give me a second. So I've been asked to talk about the Stretta procedure today. So just a quick disclosure, I have no industry relationships that's going to affect the quality of the stock, but I've done about 20 Stretta procedures earlier on in my practice. And they were mostly patients with laryngeal symptoms or post-bariatric patients that I didn't want to get into the abdomen for. But since then, I've kind of moved on to either magnetic sphincter augmentation or Hill repair for the bariatric patients, and the patients who have purely laryngeal symptoms without a lot of typical reflux symptoms or without objective evidence of reflux, I tend to shy away from doing any kind of procedure on them. Just really quickly, the endoscopic treatments for anti-reflux surgery, the quest for them has almost been like a quest for the Holy Grail, because there's a huge therapy gap for patients with reflux, with 30 to 40% of patients not satisfied with being on chronic PPI therapy in terms of incomplete symptom control, as well as there are increasing number of patients presently who are not willing to be on chronic PPI therapy or acid suppression therapy. So the challenge is obviously to try and get the valve that looks like on the right side of the screen to the valve that looks to the left side of the screen. And there are problems with fundoplication, especially in terms of training. There's so many steps of the fundoplication that need to be done perfectly, otherwise the long-term quality of life is poor. There's also a lot of subjective aspects of the operation that, again, are a hindrance in the training, as well as surgeons need to dedicate their life in terms of the appropriate long-term patient management, which a lot of surgeons are not trained to or not willing to undertake. So there's a graveyard of endoscopic therapy that have come and gone and bitten the dust. And Dr. Reavis just talked about the esophagus, which in combination with the cruroplasty seems to be making a comeback. There's also Muse, which is not presently available in America. And why have all these therapies generally tended to fail? Because they're complex procedures, the devices are expensive, they're usually startups with poor business plans, and generally the killer is that pharma companies usually hate the idea, insurance industries do not like increased procedures, and hospitals, due to poor reimbursement, don't like the idea as well. But the concept of endoscopic therapy keeps coming back, like a zombie apocalypse in the afterlife. Especially a good example is the Stretta device. It was initially designed by a company called Kurian, and it was later on sold to Medieri. Medieri went bankrupt in 2017, although they had a CPT code. And it's recently acquired by a company called ResTech, which is more aligned with the laryngeal kind of pathology of reflux disease. So some of the technical aspects of the Stretta device. The Stretta device is placed across the GE junction, usually over a guide wire. It's totally endoscopic procedure. It's performed either in the operating room or the GI lab under monitored anesthesia care. It's the same day procedure and usually takes about 40 minutes to perform. And usually approximately 12 radiofrequency applications are placed across the GE junction, very close to each other, about 1.5 centimeters around the endoscopic GE junction and including the cardia. It's usually performed with a very low complication rate, and the advantage is that there's no alteration of the anatomy, and therefore potentially the lower chances of postoperative dysphagia or gas bloat. And patients are usually put on a regular diet postoperatively. This is how it kind of looks postoperatively. Those are all the burn marks seen with the needles that go through the mucosa and heat up the muscle layers with radiofrequency energy. And generally, there are no incisions. Obviously, it's a fast recovery. It's an outpatient procedure, and lower cost with fewer side effects. So the pathophysiology of the, or the mechanism which we think that, there's a lot that is unknown about this procedure, but the mechanism that we think contributes to the decreased reflux postoperatively, post radiofrequency energy delivery to the lower esophageal sphincter is the, that it inhibits the transient lower esophageal relaxations in patients with reflux disease, and that's what contributes to the decreased esophageal acid exposure. This sham study that was performed by Carolus and his group showed that at the 6-month mark, 30 to 50% of the patients still required PPI therapy, and there was no decrease in acid exposure, and there was no healing of esophagitis. However, this meta-analysis was published in Surgical Endoscopy, which put together 28 studies. 4 of them were randomized control studies, and a total of around 2,500 Stretta patients with a mean follow-up of greater than 2 years. And this study showed that the procedure reduced the or improved the overall health-related quality of life and decreased the pooled heartburn standardized score postoperatively significantly. And about 50% of the patients required to be on, were on postoperative acid suppression at follow-up. It also showed that there was a 24% reduction of erosive esophagitis postoperatively, as well as an objective decrease in the esophageal acid exposure by a score of 3. And some of the studies had postoperative manometry as well, which revealed that the lower esophageal sphincter basal pressures increased by a mean of 1.73. There's also some small series that have looked at weight loss related surgery, reflux disease, mostly in post-sleeve patients, and the reflux, the results are kind of equivocal. Some of the studies show no difference, and some of the studies show some improvement. But they're all small series and mostly in sleeve patients. So C. Dan Smith gave this editorial in 2007 and was kind of prophetic about the Stretta procedure. And what he said was, this editorial said was, these data add to a large body of data substantiating the safety and efficacy of Stretta. Simply put, Stretta works according to the data, and does so without significant risk of any adverse outcomes. Again, these findings beg the question whether these data finally open the door for the Stretta procedure to become accepted and more widely adopted in the care of the patient with reflux. Regrettably, I suspect the answer will be no. The reason for this lies in our fear of the unknown, unfavorable reimbursement, and the disruptive nature of these newer approaches. We're all suspicious of the unknown, and there is much about the Stretta procedure that challenges our common beliefs about GERD and its management. Traditionally, we have managed GERD by eliminating the acid refluxate through anti-secretory mechanisms, or by creating a mechanical barrier with surgery. Surgeons tend to continue to reject the mechanism of action for Stretta, largely because of the lack of any physical evidence that an anti-reflux valve has been created. So I think the best indications for using Stretta are patients who have mild and early reflux, especially patients with just laryngeal symptoms, thin patients with no hiatal hernias, or patients with really bad motility, and you're worried that you don't want to put something like a Lynx or a more robust anti-reflux mechanism like a fundoplication for those patients. Especially redo cases, if you don't want to go back in there, especially if there's no herniation and patients have recurrent GERD without herniation. And generally post-bariatric patients, post-POEM patients, patients who've had other minimally invasive treatments for reflux disease. And especially the sensitive patients, the patients you really don't want to go near and do any long-term invasive procedure. Those are the kind of patients that you may want to offer the Stretta to. So generally, I think endoluminal treatments versus medical therapy, it's as safe as medical therapy. And Stretta is as easy as medical therapy with no long-term side effects. Same cost, equal efficacy, but it's a little bit more invasive. But if you're trying to compare Stretta to Nissen, it's obviously safer and easier and cheaper, and not as effective as a fundoplication. Thank you for your kind attention. And again, I hope these talks will continue beyond the COVID era. And I thank Ruchir for setting this up.
Thank you, Ashwin. And if you can stop sharing your screen and let's have everybody's video back on. That was fantastic. That was great talks. Thank you for doing that. Apologies once again, Dr. Speer, Dr. Qureshi, for messing up the order. And so I'll take a question that actually came earlier. And even though I don't think we're going to answer it today, we can still try. And the question was from Dr. Adam Sad, and the question was, why does anyone still do a Nissen? So I would love to take your thoughts on that question.
Well, I would say it's still a very good operation, and that one of my mentors that I work with here in Boston, Jonathan Critchlow, who's written chapters and in many textbooks, he would say just about anything you can wrap with a Nissen, even with compromised motility. That being said, he also does Toupets and many other fundoplications, but I think it's a very solid operation and it stood the test of time.
Thank you, Dr. Qureshi. Other thoughts, guys?
Ruchir, I'd like to add, I was trained in a place where we did tailored fundoplications. So we did Nissens as well as Toupets based on the preoperative manometry. So a lot of the studies that have been done that looked at Toupet and compared Nissen to Toupet is done outside the United States. And that's similar equivalence in the two procedures doesn't seem to have been able to be replicated in America for some reason. I'm not sure if the patients seem to be a little bit more on the obese side or the increased use of carbonation. It's difficult to know, but it doesn't seem to be that that has been replicated in the state side. So that was what makes me still do the Nissen. Yeah.
So Dr. Speer, everything being the same, a young healthy patient for you gets a Nissen or a Lynx?
I think a lot of that depends on their tolerance for having a procedure that's not quite as tried and true as Nissen. Like Dr. Kurian was saying, there's a lot of good data longitudinally for Nissen. And so I think it really depends on the risk profile that you're willing to take, since Lynx is a little bit newer. And then the other aspect to that, just to be completely honest, is insurance as well, and how desperate patients are for surgery, because you can do a Nissen any day, but it's really hard to get Lynx through insurance, as I kind of alluded to.
And also, I mean, in many situations, some patients just don't want a device. They're
Exactly.
foreign body inside their body.
Exactly. Yeah.
But Reavis, any thoughts on that?
Sorry, I was muted. Oh, sorry. Can you repeat the question? I was just responding to someone.
So, why do we still do Nissens, or do you think there's a place for Nissen still?
Yeah, no, I think you know, in our institution, Blair Jobe actually published a paper when he was in the research lab with Lee Swanstrom back in '98, looking at long-term Toupet versus Nissen, and at least in our hands, and this is again during my residency as opposed to during my faculty years, the durability of the partial fundoplication was less than that from the complete fundoplication. And again, as both Emily and Ashwin know, we've had a long, successful track record at our institution with complete fundoplication. So in those who are candidates, that's what we stick with. And I think with a lot of the door type fundoplications out of Australia, we have to recognize that even though the eponym is the same, the procedures vary quite a bit from surgeon to surgeon to surgeon. And so that's why I typically in my reports, I say complete fundoplication, because what I do and what Rudolf Nissen described are not really one and the same.
Yeah, I think, Kevin, you bring up an excellent point. I think how we all do our Nissen, I bet you each one of us here, for those of us who still do Nissen, and I don't mean just a Nissen, but I mean a Toupet. Every anti-reflux procedure, the principles are the same, but the actual technical components are slightly different. For example, I was taught the Demeester method for creating a Nissen, and I'd love to see, you know, and I was recently speaking to Dr. Oschlager in Seattle, and he was like, you know, that's no way to do a Nissen. So, you know, it's really interesting, and I don't think that's been standardized, and I think that's another potential opportunity, and I agree with Dr. Kurian that this would be awesome place for us to talk about, you know, the real nitty gritties of maybe how do I do my Nissen, and have different perspectives from each of the different groups.
Yeah, I completely agree with Qureshi. And as the studies that I showed, there's a lot of heterogeneity in, you know, the size of the bougie that was used, the size of the wrap that was used. You know, I mean, 36 French nasogastric tube is pretty darn small. I mean, you can definitely expect some dysphagia after that. Now, that said, there are many surgeons who perform Nissen without any bougie at all, especially many who are doing it robotically. So even though I do robotics, I don't do a Nissen robotically, I do a Toupet. So yeah, all great points. And the next question.
Ruchir, can I add something to that?
Yes, please.
So I've been a very slow adopter of the links. So I kind of started doing links after Lippem presented his kind of 8-year data at SAGES a couple of years ago. But your question was, you know, all things the same for a younger patient, would it be better? What would be better? Obviously, it kind of depends on the patient, but a lot of patients, you know, you go through this whole thing and it's very technical for them. And unless they have like a real emotional response to one or the other, most patients kind of ask you like what your opinion is. And you have to choose one or the other for them. And generally, I think lately, over the last year or so, especially for the younger patients, I think the links is a better surgical procedure as long as you've really selected your patients out appropriately.
Right. Yeah. The great point, Ashwin. And I feel the same way. And I think Nissen is still an excellent operation. Loose floppy Nissen for young people with GERD is still a great operation if they don't want the links. And the next question that came from Dr. Kevin L. Hayek was, is pre-op manometry only helpful in terms of the fundoplication or the wrap to rule out achalasia? So, and I don't know what you guys practice is typically for large or giant esophageals. I don't get a preoperative manometry. I just fix it and usually do a Toupet. And the data kind of, you know, as some studies comparing Nissen and Toupet showed, the people who had motility disorders did not necessarily have worse dysphagia post-operatively. So are we just ruling out achalasia with a manometry or maybe some motility disorders, or do we really need to still tailor the fundoplication?
I'll take the counterpoint, and that is we get them on all of our patients all the time, if for no other reason to establish baseline. There's nothing more disconcerting to have a patient come who is post-op from wherever, and they have dysphagia or whatever sequelae, and you have absolutely no idea what their original baseline was. You may have a post-op baseline that says their wrap is too tight, but you have no idea if they had IEM or if they had esophagogastric outflow obstruction preoperatively. And so counseling someone that doesn't have baseline is very challenging. Now, I've seen many reports and presentations about how the worst part of the workup is motility. If you ask a patient what they dread the most or what they don't ever want to do again. And that being said, but I'm always able to convince them that the most important thing that I do is establish very, crystal clear where we are to start, because all future recommendations will be based on a combination of where we started and where we are now. Again, the same goes for doing pH testing on PPI medication. Our gastroenterology colleagues do it because they want to make sure that the medications are functional at squelching the reflux. The problem is they may have a Demeester score of 2 on meds, but they may have had a Demeester score of 2 off meds, but we have no idea because the testing was not done that way. So we do a lot of repeat testing, both motility and pH testing for those exact reasons, to establish a crystal clear baseline before proceeding.
I do the same thing, and full disclosure, 2 out of the 5 surgeons here in this panel were trained by Dr. Reavis, so we probably do things pretty similarly, but I do like to know what my baseline is so that if we have some problems post-operatively, I know exactly where those could have stemmed from, what our old baseline was, what our new baseline is now. And it is not uncommon for me and my elderly population with lots of lung disease to see patients who just have terrible, if not absent, motility. And they're not complaining of dysphagia whatsoever. And that does, from a physiologic standpoint, give me a little bit of pause with proceeding with a nice tight Nissen fundoplication, or I guess loose floppy Nissen fundoplication. It does make me feel a little reluctant to proceed in that with a full wrap.
So, so I was trained by Dr. Reavis, and the 3 out of the 5 people are from the Oregon clinic, so where we do a lot of testing. So I do everybody gets like a manometry preoperatively. And I think, a lot of surgeons have, it's difficult to get manometry out there unless you really put your arms around it and bring it into your office. It becomes very difficult to kind of order a manometry and get it, because the patients hate getting a manometry. The reimbursement is poor, so the GI physicians have really no interest to do it. They would rather kind of stay in their surgery center and kind of do endoscopies all day long. So again, this is kind of a caveat for people who are kind of doing anti-reflux surgery to kind of put your arms around, especially preoperative testing. It's a huge, hugely important aspect of taking care of these patients, and trying to get a baseline is important. There's a lot of studies, I think, that go back and forth to show that, the most important predictor for postoperative dysphagia is preoperative dysphagia. But I think the Oregon clinic, they recently, I think Ezra came out with a paper that showed that poor motility preoperatively along with preoperative dysphagia increases the sensitivity for the prediction for postoperative dysphagia. Again, with high resolution manometry, you get to see a lot more kind of funky manometry results, like EGJ outflow obstruction, that you kind of are scratching your head and wondering, well, what to do with these kind of results. But I generally use intraoperative endoflip to kind of do another kind of intraoperative manometry testing to kind of get another little bit of piece of information in the operating room before I wrap the patient, whether they need a short myotomy or not. And that is how we were trained as well. We were trained to do like a limited cardiomyotomy with a partial fundoplication for these patients with EGJ outflow obstruction. And it's more prevalent than you give it credit, especially when you test a lot of patients preoperatively. And I think generally, unfortunately, if you want to do this kind of surgery, you kind of have to be an esophagologist a little bit. And sometimes more information, we like more information than less information. So especially when you're trying to do a surgical procedure that has such a significant impact on their quality of life if things go badly.
Yeah, all excellent points, and I agree completely. And I just like, sometimes it's hard to wrap around the head around manometry, but just like we do preoperative esophagograms and endoscopies on our patients just to establish baselines for post-operatively, so on and so forth. Manometry is the same way. And completely agree, Ashwin, about the preoperative dysphagia being predictive of post-operative dysphagia. And yes, the manometry does tend to pick up a lot of minor disorders, but I think, yes, the utility in terms of picking up major disorders is definitely high and definitely should be utilized. And looks like we don't have any more burning questions from the audience. Thank you, Dr. Qureshi, Dr. Speer, Dr. Rios, and Dr. Kurian for your time. Fantastic talks, everyone, and see you all soon, hopefully at SAGES in August.
Thank you.
Thank you so much.
Thanks, everyone.